Okay, the webinar is being recorded.
So good morning, everyone. Thank you so much for joining the call today. If you are able to mute your phone, your personal phone, please do so. We are hosting this call as a follow-up to the technical assistance that CAI provided to the Atlanta EMA in March 2013. During that technical assistance session, we had 4 objectives, and I just want to review those objectives because we won't be reviewing the information that we provided in the initial technical assistance on this call. We'll go over the purpose for this call shortly. So in March, on March 15, 2013, we met with the Part A program, and our objectives were to look at patient navigation, look at the program models, outcomes, and cost effectiveness. Additionally, we looked at patient navigation and its application in HIV/AIDS services. So we gave some very specific examples of that, both during the technical assistance session and in the written materials that follow. The third objective was to describe peer-led HIV/AIDS support services, including peer-led HIV/AIDS patient navigation. And so we provided examples of how patient navigation can be either led by a peer or a professional or a peer professional. And number 4, our objective was to discuss potential application of patient navigation program models for the Atlanta EMA. So as a follow-up to that meeting in March, the Part A grantee asked CAI to answer some very specific questions. So Leah, you can go to the next slide. Okay. So the purpose of this call today is in response to the follow-up technical assistance request to look at patient program navigation models that the Atlanta EMA could consider implementing as a pilot or as a full program in for the Atlanta, Fulton County, and other county area. Next slide. So the Atlanta EMA's goal for this program is to identify individuals who know their HIV status but are not in care, to inform them about the available treatment and services, and to assist them in the use of those services. The focus of the program that the Atlanta EMA expressed an interest in using as a potential model would be to support clients in accessing available services for HIV/AIDS treatment and support. Next slide. So in order to look at what model CAI could recommend for the Atlanta EMA, we reviewed several documents, including your HIV/AIDS comprehensive plan. We reviewed a report by the assessment committee, the challenge of unmet need, and we also reviewed the consumer survey completed by CTEC, the Southeast AIDS Education and Technical Assistance Center at Emory University School of Medicine, to look at what are issues that a patient navigation, a patient-client navigation program within the Atlanta EMA could address. So one of the things that was most clear, and this was stated by CTEC from the consumer survey, is that the highest ranked barrier is related to unfamiliarity with the continuum of care, suggesting a need for increased communication by providers of available services. Interestingly enough, if you recall, when we met in March and we did the activity and we put up post-its about what do you see as barriers to clients accessing services or remaining in treatment, many of those post-its that you all identified as members of the Planning Council were related to communication, just as identified by this statement in CTEC's completion of the consumer survey. So I think that it's clear that although the information may be communicated to clients, there may be a need for further assistance for them to actually access the services that they need. Next slide. Okay. So there are a few things that came from the consumer survey that also are key to looking at why a patient or client navigation program model, the type of model that you should consider implementing. So one of the things that is apparent is that there is a 30-day period before the initial assessment, and this is from, again, the consumer survey. There's also a 30-day period before the first treatment appointment. And so what that means is someone who receives their diagnosis has a waiting time before they're actually entered into the system. Hi, can you please mute your phone? Okay. Okay. So what is clear is that once someone receives their initial diagnosis, there is a 30-day period before, there can be a 30-day period before their initial assessment, and then another 30-day period before the first treatment. Now, this depends on the site. I'm sorry. Someone who joined the call, could they mute your phone? Okay. So after finding out that they're HIV positive, 59%, and this is the number of people that responded to this particular question, 419, reported that they needed mental health services, that they suffered from anxiety or depression, and or reported substance abuse. This information is key because it speaks to someone's readiness to hear and act on information that they are provided. So although when someone receives the diagnosis and even goes in for their initial assessment and goes in for the appointment, there may be a need for additional follow-up to support them in actually accessing those services. And this data, again, is from the consumer survey. So the next slide talks about the type of model that we, CAI, and this is the request of the Atlanta EMA, is recommending. So our recommendation is that the Atlanta EMA implement a patient navigation client support program to engage and actively navigate newly diagnosed and persons at high risk for non-treatment adherence to HIV/AIDS care and support services, and to increase their knowledge of HIV/AIDS treatment and support available in the Atlanta EMA in order to achieve improved outcomes. So again, we're not going to go over whether or not patient navigation is effective. We provided a substantial amount of information both in the training that we did in March as well as in the written documentation that you should have received in your folders. Patrick also has that information that he could send you electronically that shows that patient navigation has been shown to be effective not only among cancer survivors, because that's where a lot of patient navigation programs originated, but also in HIV/AIDS services. So we know that that patient navigation is effective. So what we're looking at is in implementing it in the Atlanta EMA. The focus would be on persons who are newly diagnosed, particularly since the information that I just provided previously during the waiting time as they access services. Once they receive the information, having somebody to actually walk them through how to access treatment and support services in order to increase their adherence, or to support increasing their adherence and also their knowledge of HIV/AIDS treatment and services. Next slide. So this program would be voluntary. It's always important that people know that it's voluntary. They would not have to work with the patient navigator or client support program, but the idea is to let them know that this program is available to them. And letting them so that they can access it at a time when they are ready. Again, it's not that some of this information or all of this information is not being provided to clients. It's reaching a client at a point when they are ready to hear and receive and act on the information. So this would be a voluntary program or service, and clients would be informed of its availability, or that the patient navigation client support program is available to them at any time. And the program would use evidence-based methods, and I'm going to talk a little bit later about the training that's involved. It's important that when you implement a patient navigation program that there is training for the persons who are serving as patient navigators and also for the supervisors, and just a general orientation for the clinic staff. Because the important thing is that this augment and complement the services that are already being provided. It's not a replacement, and there are times where it may appear to be overlap, but that overlap may be necessary in order to reach those who are most vulnerable or most at risk for not remaining in care. So the other thing, navigating them through the process of how to access community and clinical resources to address individual barriers that may prevent them from accessing treatment services. We included that note because when you look at the consumer survey completed by Emory, it was clear that the issues related to people accessing care were individual barriers were the primary reasons that people didn't access care. It was not structural, so it was not how the system is set up necessarily. It seemed to be that people were not remaining in care or dropping out of care based on things that were happening in their own lives. So one of the tasks of the patient navigation program is to also ensure that persons know about community resources that may be available to help them navigate through the issues that may be impacting their care. Next slide. Okay, primary activities. The primary activities of the Patient Navigation Client Support Program is to link, retain, and track persons living with HIV/AIDS in medical care, medical case management support services, and health education programs. So again, this program is to really support clients in accessing services that are available to them. If you look at the caseloads of most case managers, in terms of the numbers of clients that they deal with on a regular basis, the clients who will not remain in care and access care on a regular basis, they may follow up with them, but caseloads may prevent them from following up with clients who are regularly non-compliant or who are at risk for non-compliance. And I'll give examples of how the patient navigation program in one of the other areas of Georgia supported case management, and there wasn't an overlap in the work, but how they worked they worked together to ensure that clients were able to access services. Another task would be to coordinate the collaborative efforts of treatment navigation for patients across a network of citywide providers. When someone is dealing, and I showed you in the slide before the data that CTEC had on the anxiety and depression that was experienced by the majority of clients who receive an HIV/AIDS diagnosis. So navigating a system, a citywide system of providers for someone who is dealing with their HIV/AIDS diagnosis both emotionally and in the context of their lives may be difficult, and they may need additional support in knowing how and where to go and how to access the services. Next slide. Okay, education is a key component of the job of the patient navigation program. In both the comprehensive plan for the Atlanta EMA and the consumer survey that was conducted by CTEC, there seems to be a gap in patient and client information about HIV/AIDS, not only about HIV/AIDS services, but just HIV/AIDS treatment. For example, if you look at why people stated that they did not take their medicines, some said that they felt well, and so they didn't take their medicines because they felt well. Now, there are many people who don't take their medicines because, or aren't adherent to their treatment plans because of homelessness. That seems to be one of the key factors or that put people at risk for not being compliant with their HIV/AIDS treatment plan is homelessness or unstable housing. But there is an opportunity for this patient navigation client support program to really focus on working with clients about basic HIV/AIDS education. What we have found, and Abigail McCulloch is on the line with me, what we have found when we trained patient navigation programs in other areas, not just in Georgia but in other areas, is that a lot of times clients have basic questions about HIV/AIDS services that they don't ask the clinician. They may not understand fully the information that's being provided to them, but are reluctant to ask the type of questions that they need to ask in order to better understand how they can actively engage and support their own care. The great thing about this program is that it would allow an opportunity for a person to work with someone who they wouldn't necessarily see as a clinician and ask them basic HIV/AIDS questions and link them to, because there are HIV/AIDS educational opportunities within the Atlanta EMA. Some of the agencies provide HIV/AIDS 101, those types of classes, so that the patient navigator could link the client to those. Again, always at a time when the client is ready to ask the questions and learn more about care. Another key task of the patient navigation program model that we're recommending is to make regular phone contact with clients and update the clinical team about any issues that may impact the client's medical care. And this recommendation is from reading across several of the documents and also what consumers say about what they need. So one of the things that was clear from the consumer survey is that when people received follow-up, they were more likely to attend their medical appointments. So just a phone call to ensure that the person knows the time of the appointment, knows how long it may take, knows what paperwork to bring. This is information that a patient navigator can provide to a client, relieving that task from a case manager as needed. So, and this can be done on a targeted basis with clients who are at high risk for noncompliance. And I'll talk about the target populations we're recommending in the next slide. Leah, next slide. So one of the things that happens during the training is there is a clear demonstration or discussion of what the role of the patient navigator is and is not. That's why when you have a patient navigation client support program and you offer training, it's important that it be offered not only to the patient navigator but also to the supervisor. And then what we also recommend and what we've done in the past is we've offered kind of just a 1 to 2 hour overview with the entire clinic so that so that everybody understands what the patient navigator's role is. And also we have an opportunity to really talk to staff about the fact that the patient navigator knows that they do not answer specific questions regarding medication usage or any type of specific medical questions. That is one of the things that's trained very clearly when a program is implemented. Patient navigators, client support staff are told exactly what they can say to clients, but what they can do is provide clear statements that would be formulated by the treatment adherence nurse or by a case manager, and then actively navigate the client to the appropriate clinical person to answer their questions. But we wanted to highlight that is, answering any medical or specific health-related questions is not the job of a patient navigator, and that's a part of the training that they go through about what they should and should not answer. Also, patient navigators they would not serve as buddies or companions. That's not their role. The role of this program is to help, and as you help, teach clients how to access services with the goal of helping them remain in care or reducing the likelihood that they may not be adherent to their treatment plan. This is for a specified period of time. This is not an ongoing program that you would serve as a buddy or a companion to a client. Because ideally, you're trying to build the client's capacity to access services on their own. The next slide is, it talks about, and this is information from the consumer survey. When we looked at the consumer survey, we said, what are reasons that clients, why did they return to care after being out of care? So this patient navigation program model that we're recommending is for clients who are at a high risk for not complying, for not being in care once they've received their HIV/AIDS diagnosis, and then clients who are returning to care. So working with the patient navigator may be a way to support them in remaining in care once they return. So we looked at the client survey and said, what were reasons that clients returned to HIV/AIDS care? And the reasons noted were, one, they got sicker. I was able to deal with other problems. Remember I said that a lot of the barriers, it seems, as reported in your data for the Atlanta EMA, that prevents people from being in care. One of the top ones is stigma. They don't want anyone to know, so they aren't taking their meds or not participating in care. But another one is the HIV/AIDS happens in the context of their lives, so it tends to be individual barriers. So they said the top 3 reasons that they returned to care were, got sicker, I was able to deal with the problems, and someone helped me. And so when you look at implementing the patient navigation program, part of that is to address what consumer says, this is what I need, this is how I got back into care. And once they come in, once they make the initial step to re-enter treatment, the treatment and care services, then they have an opportunity to work with the patient navigator to help them maybe deal with some of the barriers that that they found when they were in care and they actually stopped attending care and treatment services. So when we first talked about implementing a patient navigation or client support program, one of the things that the literature said is that there has been, and this is the literature that if you look at outcomes data, that these programs have been particularly successful when targeted to certain populations. A lot of these types of programs are used to address health disparities. For example, when the state of Georgia implemented, they implemented a peer program that included patient navigation. They were able to receive funding from the Minority AIDS Initiative to address health disparities among populations in Georgia in their remaining in ADAP services. So their problem statement was very specific around populations who were at risk, and they had data to show that they were at risk for not remaining in care because of their inability to remain, have access to ADAP. So in looking at all of the data, including your comprehensive plan for the Atlanta EMA, to see which populations are at risk. And for your consideration, certainly as a planning body, you allocate and you choose the priorities for the usage of the resources that you have. But the populations that we noted were African American men, and that's men who have sex with men, and that seems to be the group with the highest risk for not remaining in care. MSM, according to your comprehensive plan, have a 42% greater risk of not remaining in care. Men who have sex with women and men who have sex with men and women. We noted all 3 because it's important that whichever target population you have or that you choose for the patient navigation program to focus on, that the persons who are in the positions be able to relate to and work with any client who comes in and is receiving services. Another population that is at risk for not remaining in care for many reasons, some of which have to do with the system of services, some of which have to do with language barriers, are Latino populations. They were also noted in your comprehensive plan and in the consumer survey as populations that are at risk. One in particular that we noted are persons living with HIV/AIDS who have been recently released from incarceration. And we know that there, at least in DeKalb, there was a program that did discharge planning for persons who were post-incarceration. But it seems, based on the consumer survey, that this population, once out of jail, has a very high risk for not remaining in care. And some of that, it appears to have to do with stigma, but the answer that they gave in greatest numbers as to why, and this is when, according to the consumer survey, when surveying persons who were previously incarcerated as to why they weren't in care, is that they didn't know that insurance, they didn't know that the service was available to them. So again, that's a lack of knowledge. That's based on what the client says. Other groups who are at high risk, transgendered persons, and this is information you already know, but this is just to say, as you look at your patient navigation program and who to target, these are populations that stand out that may benefit from the use of patient navigation and client support. Transgender persons and also persons who are homeless. The next slide, please. So one of the other questions that the Atlanta EMA asked us to provide information on was the salaries for patient, and we put all of these titles in because when we looked across many job descriptions across the U.S. for patient navigators, peer support, and community health workers, the salaries vary by jurisdiction. But the average, on this slide, we're showing you the average hourly rate and full-time salary. So it seemed to be two groups, and this is from the HRSA Target website, but we also provided information from some specific jurisdictions directly to the Atlanta EMA grantee staff for their review. So that's the salary information. That was information that was requested about the types of salaries for this position. The next slide, please. So the other information that we were asked to address that is important is what are the knowledge, skills, and abilities of a patient navigator when you're looking at your job description. And we also, just so you know, we provided the Atlanta EMA grantee staff with a copy of a supervisor's manual that CAI developed for the Integration of Peers program, which contains policies and procedures, job descriptions, performance appraisals, lots of information from other jurisdictions who have implemented this type of program, and they're sample, and you're free for you to use any of the information in developing your and tailoring your particular program to meet the needs of Atlanta. But if you look at the knowledge, skills, and abilities that we're recommending for the patient navigation program that the Atlanta EMA would establish, and they're listed here, but the ability to work effectively with a wide range of constituencies in a diverse community. And that speaks to the fact that depending on which your target populations are, that the patient navigator would need to be able to work across multiple communities to address and navigate clients to the services that they need. Knowledge of HIV/AIDS services, resources, and barriers. And we included barriers because if you have an idea of what it's like to go through the system and go through the appointments and how to identify a dental provider, if you know some of the things that are barriers to that, it's sometimes easier to walk people through how to address them. But they have to be able to, they have to have strong knowledge of HIV/AIDS services, resources, and also be able to impart that information to clients. That's part of why the training is important. Training provides tools and methods to work with patient navigators about how to provide education to clients. So the next knowledge, skills, and abilities is ability to provide practical, non-clinical HIV/AIDS education. And again, that is a key task of this, a responsibility of this position. And in the training, tools and delivery methods would be provided to the to the patient navigator so that to increase their ability and their skill to work with clients directly. The ability to collaborate with other staff to serve clients, and that's important. One of the things that I have found, and I've done a lot of follow-up technical assistance after clinics have implemented patient navigation and peer support programs, is really trying to work with the person to understand their role within the clinic and the importance that they work with the team. That, their responsibilities, making calls to clients, following up on clients about their ADAP paperwork, all of those things are key, and it's a team effort, but making sure that they understand that you are working with the team to serve clients. And so you need someone who is able to work across the clinic staff. Ability to appreciate clinical and legal requirements and restrictions, and of course that has to do with confidentiality. The training that we provide for patient navigators, one of the key issues, we're not giving all of the detail in this presentation, is about boundaries. Those boundaries that are discussed are important because those boundaries also address some of the legal requirements in providing services. So ensuring that people understand that once given the job description and boundaries that they can comply with those in order to ensure that the clinic and the program is not at risk. And the clients are not at risk. Strong interpersonal and communication skills, ability to prioritize and self-motivate, record maintenance skills, and time management skills. We did not include detailed information on the tracking information because the tools that you use for your evaluation and the tools that you use to track the interaction of the patient navigator with clients, once those have been determined, and they are, and usually they are ones that would facilitate the information being added to care, where then the person would need to be able to use those tools, and if you have them enter it or whomever, or provide the information to the person who would enter the data in CareWare, because you do want to see if the patient navigation of clients who participate in the patient navigation program, you want to see what the impact is in terms of their remaining in care or their compliance. And you can also assess it through a consumer satisfaction survey. So the next slide, in the next slide we talk about just training. So when you train a patient navigation program, when you provide the training, it's both didactic and skills building multi-day training, and Rusty asked me to be very clear about this. He usually does 4 days with the actual patient navigator or client support person and 3 days with the supervisors. And I believe there is an overlap on the first day. And part of the reason for that is being very clear about the navigator's roles, the job tasks, the necessary skills, how to interact with clients. So we go through a lot of methods, including some behavior change theories so they understand, how to kind of assess when a person is ready to receive information, what are tools that you can use to show them and to provide the education, and also dealing with some boundaries. Dealing with boundaries is always important because some of the times the clients will push the boundaries, and making sure that the patient navigator is comfortable with understanding what they can and cannot do or say, and that they also know when to speak to their supervisor to get support in working with the client. Next slide. The training would include evidence-based methodologies to assess and engage clients, including basic HIV education methods and tools, enhanced outreach relational outreach engagement model, and behavior change theory. And I've already mentioned behavior change theory. The enhanced outreach relational outreach engagement model is just a model that works with, it's not actually outreach outside the clinic. It's how to work with someone even as you're calling them to remind them about their appointment, but it's how to engage someone and build a relationship in a way that at a point in time they are ready to assume full responsibility for the information that you have imparted. So it's just a way that you work with the client and talk with them and support them, that does not attach them to the actual patient navigator, but really works with them to know how and build their capacity to navigate the system on their own. Next slide. Okay, I think that slide may be a duplicate. Next slide. The goal of the training program is to it focuses on how to support the patient navigators in how to assess and engage clients and build appropriate relationships. And I say that again because it is key that patient navigators know what type of relationships with clients are important. We've seen these programs implemented across the U.S., and sometimes when clients come to HIV/AIDS services, they come with many issues that may impact their care. And it's important that the patient navigator or client support service understands what is their role and what is not their responsibility in supporting the client in. And I say that because when we have done the trainings before, we've had to work with them about not having clients call them after hours, not giving personal cell phone numbers to clients, just really understanding what is an appropriate relationship with the client. And again, if at a point they don't feel comfortable or feel like the boundaries are being crossed, how to work with their supervisor to address that issue. Again, and because this all is about working with the clients to support them in making decisions about their own health care and their own personal strategies to maintain and remain in HIV/AIDS care. Ongoing training for patient navigators would be assessed by the supervisors along with whatever training entity. What we have found is once we do follow-up calls just to look at how the program is going, what are questions the clients have, because it may come up the clients have a particular types of questions that they're asking on a consistent basis. And so we might provide tools or some strategies to the patient navigator on how to address those questions. What we also find is once people have done the job for a while, they have an idea of what other information they need to be more successful. What we did for one program that implemented the project, and they had training, ongoing training every year. So in year 2, we did another HIV/AIDS 101. We did a refresher because they also had peer navigators that left, and they needed the new staff to be trained. We also did a training for them on motivational interviewing. That was a training that we thought would support them on how to better engage and work with clients around, again, not having the person depend on the patient navigator, but really look to their own resources and strengths and motivation to engage in their own care. So that was a training that we offered for that particular client in year 2. But that would be assessed by the supervisor along with the training entity. The next slide. The Atlanta EMA also asked us to give an estimate of the training cost. And I want you to know the range on this slide is so broad because it just depends on how many patient navigators you are training, how many supervisors, so this is just a general estimate. It's a multi-day training, so you're looking at the cost. What the cost includes is the cost of a consultant, one consultant or two. If you are training a large number, as we've done in the past, we've trained about 14, up to 14 peer navigators, client support persons, and their supervisors at one time. That cost was it really was closer to $25,000. If you are looking to train just a pilot program, it could be as low as $10,000 and maybe slightly less because you would not need 2 consultants or 2 trainers. The materials would be substantially less. The travel would be less. So once you have determined exactly if you're going to implement this, if you decide to implement this in one clinic or at multiple clinics, the cost that you'll incur will be based on the number of people and sites that you're going to train, and then the number of days of the training. But just know that to do a comprehensive training for a peer navigation program, an initial one, it should be at least 3 to 4 days. follow-up technical assistance. We always recommend that you monitor a program and provide follow-up TA, and that can be done by conference call. And you should probably consider having a regular conference call with the peer navigator or peer navigators, however many you're going to hire, a monthly call, and that's just to check in to see any questions, any barriers, any issues. And then you could have a call every 2 months with the supervisor. What that would allow you to do if you did that with the pilot program is if you find that the program needs to be changed, the job description needs to be changed, or the program needs to be more tailored for a particular clinic site, or even your evaluation needs to be tweaked. That's how you get that information, by doing a monthly check-in, and it usually is no more than an hour. It's a conference call. It's an hour. Any issues that need to be sent to the supervisor would be sent on to the supervisor if the call was just with the training entity, or the supervisor could ask for support. We have had calls with supervisors in Georgia the state of Georgia, when they first implemented the integration of peer programs, and that's how we identified our trainings, our upcoming trainings for their program, is by talking to the supervisors about what they were seeing and what they thought that the peer program or the patient navigation program needed. So I hope that the information provided today answers the questions that the Atlanta EMA wanted us to answer to support them in identifying the type of patient navigation, peer support program, or patient support program that they are considering implementing. We are available, that is CAI, to answer any additional questions. We do have a few more job descriptions and program profiles to send to the Atlanta EMA. We're waiting to receive one from the state of Alabama that has a program, just to share with you, so that as you make your decisions, you have examples from other jurisdictions that can support you in really determining what is the best program for Atlanta. And at this time, Leah, if there are any questions that anyone typed in, or I can answer any questions by phone.
Okay, thank you, Cassandra. I'm going to unmute the lines. I muted them to avoid feedback. So we are open for questions. If there's ambient noise and you don't have questions, I would appreciate if you would just mute your line. Thank you.
Catherine, are you on the line? Catherine?
Yes, I am.
Catherine, this is Tony Rick.
Hey, Tony.
Oh,
Hi, does anyone have a question?
Yes, this is Trevor Pearson. I noticed that in a number of the contacts to the clients, there was a lot of discussion about phone calling. But I know that in our modern times, most of our clients change telephone numbers quite often. Is there another method of contact that you would recommend? Perhaps, for example, Facebook or the other new methods that our clients use today?
So that's a very good question. So it depends on what and let me just go over some of the issues related to that. Particularly for clients who are transient, they don't have stable homes, we have found that it's very hard because their numbers do change frequently. But it really is incumbent upon the client to provide the best way to communicate. I'm so sorry, Leah, can you mute one more time? Sorry, I wanted to make sure. Particularly among clients who are transient, we find that their phone numbers change frequently, but it really is incumbent upon the client to share the best way to reach them. And what I mean by that is, throughout all of the documents that we review, there's clearly a fear of someone finding out that a person is HIV positive is a barrier for people seeking care. So that, rules out writing, calling landlines if that is not their home, if they're living in a home with someone else. So that's why it's really important if you establish a program like this that you make it clear and make a number available, including, because Atlanta has, for example, a hotline. So even if the person can't remember how to reach the patient navigator, they could always call through your hotline and say, I'm trying to reach the patient navigator who I spoke to. And that makes it easy for the client to reach you. Because if they don't, they could always give you an email address. The only thing about working with email addresses, it depends on what your clinic policy is, because you run into potential issues with confidentiality being breached. So you have to, I wouldn't necessarily recommend that. They could email the client just to send an appointment reminder, but beyond that, you really can't email any additional information. So the important thing is to make sure that the client knows how to reach the patient navigator. That way, if the client's phone number changes, they could also, because remember, what we're also trying to do is the responsibility of the client to engage in their own care. And so making sure that they know that the service is available and that they can access it is the goal, not for the person to try to track them. I'm sorry, did that answer your question?
This is Trevor. I'm more thinking of our younger population. There are a lot of young people who may not even have cell phones, or how do we keep in touch with them?
So again, that depends. Do you, in your clinic now, do you all provide appointment information by cell phone or by email or by text? If that is something that the clinic does, then the patient navigator could certainly use it. According to your data, and this is from the Atlanta EMA's comprehensive plan, and I'm not saying that young people shouldn't be a target population. Remember that these types of programs, the best thing to do is to use them at those that are at highest risk. The age group that's at highest risk for noncompliance, according to your comprehensive plan, is age 40 to 49. So and so I'm not saying that young people are not at risk, but if you're looking at using a program like this, because you may just be using a model, so you want to target it at a population to see, is it effective in this population. If you look at the folder, the initial folder, and Trevor, I'd be happy to email this to you. There have been many of these types of programs that have been used with young people with great success using, I can't say whether or not they use Facebook, but using technology. According to the data for the Atlanta EMA, I'm not certain that is, if you're trying to reach the persons at highest risk, that you want to start with the youngest people. Because my understanding is this isn't something necessarily that's going to be implemented across the EMA. It may be that you are considering a pilot to look at its effectiveness. But these types of programs have been used with young people, and I can give you that information. Again, we sent it electronically, using social media, using other things, but it depends on the clinic's policy, because the person can't operate, the patient navigator, once they are a part of the clinical team, has to operate within the context of the clinic. So they can't do anything that is not necessarily part of how the clinic provides services.
Cassandra, this is Patrick.
Mm-hmm.
We sent you a couple of questions through the text.
Okay. Leah?
In the meantime, we just wanted to make an observation. Dwight Curry Anderson has observed that some of what you described is similar to the ARTIS model. Mm-hmm. Are you able to comment on that?
Mm-hmm. We looked, I know, and this was a question and comment that we had when we had follow-up questions with the Atlanta EMA staff. We note that ARTIS is being used. I don't think it's being used across Atlanta. The issue with ARTIS, or the difference between this program and ARTIS is an evidence-based model that's a multi-session model. But it is a session, meaning it's a prescribed session number of sessions with a client, and with the entire point of increasing their adherence. This program is basically patient navigation. It is helping clients access services and giving them information and providing them with education based upon their readiness to receive it. So unlike ARTIS, it's not, if a person decides to talk to the patient navigator just to get help with finding, let's say the person's trying to find a support group to go to, or they just wanted to ask them, have you been to a support group, or do you find the support group to be helpful? A person can ask the question or receive a service from the patient navigator without having to see them on an ongoing basis. So it's client-centered in that it is available to the client at a point that they're ready to receive it. ARTIS is evidence-based, so and as I said, I know that it's being used in Atlanta. We discussed it when we did the training on March 15th as a potential model for you all, knowing that it has been implemented not across the EMA, but it's been implemented in some sites. But do know that that's an evidence-based model that is a multi-session model that doesn't have a focus just on navigation. That model is really about building client adherence, their capacity to adhere to a program. So they wouldn't be contradictory to each other. They could be a complement, because a patient navigator can say to someone, you know, we have this program that's available, ARTIS, for you to participate in. Not all clients are going to be willing to go through ARTIS.
We have a follow-up comment.
Sure.
That if the patient is already positive and dealing with a positive patient, is trying to bring him up to level where they are. To me, that's what I'm sounding like. In other words, this goes back to my question. It would not take a RN to help a patient to get back into care.
Absolutely. So that's a good question. I'm just going to tell you, for example, how it was used in one of the sites in Georgia. Okay, so the good thing about a patient navigation, it does not take a professional. This person does not have to be a clinical professional or medical professional to be a patient navigator client support person. As a matter of fact, one of the key aspects in all the literature that we provided to you stated that a person who identifies with the community or someone that people can see as a peer, it doesn't mean they are a peer, but see as a peer, is one of the key aspects of the program that clients find helpful. Because there are times, no matter if the treatment adherent nurse or the physician, they are sometimes seen as authorities by the client. And so they won't tell or share or ask the types of questions that they need to ask because they see the person as an authority figure, and sometimes they don't want to challenge it or just don't feel secure enough to ask the questions that they could ask someone who they saw as a peer. And that was in the literature. If you look at any of the information that we provided, and what the clinicians found is that having a patient navigator or the client support person actually increased the communication between the client and the entire staff. So for example, you said you don't need a person, a nurse or someone like that to make calls to a client. We had a clinic, and we shared this example with Patrick and Candace, that there were persons who were in HIV/AIDS care who regularly did not complete their ADAT recertification on time. If you don't complete your ADAT recertification, you cannot get your meds. And so what they decided, this clinic decided, the case manager and the peer, this person was a peer, it doesn't have to be, but this person happened to be a peer navigator, is that the peer navigator would call this list of clients to go through each one of the items that they had to bring to complete the recertification and ensure they understood, you have to bring, your pay stub. You have to bring, so they would go over the data, and they went over it with them. They called them prior to the research to make sure that they were in on time so that the paperwork would be smooth. So that's a part of facilitating the client, completing the paperwork so that they can remain in care. That task was given to the peer navigator under the supervision of the case manager. and their supervisor. But it actually helped, and they saw that with their clients that they had less issues with clients completing recertification on time as a result of having that step. So those are the types of things that the team can look at to say, how can this program complement and help us, particularly for those who are at risk for being non-compliant, help them stay in care. And what this clinic said was, our issue is that people don't complete, don't recertify, and then they lose their ADAP. And ADAP has a waiting list. So this is not, it's important that people who are on ADAP have the information and have their information submitted on time so that their care and their meds are not impacted. And so that's how the clinic said this is a role we think our peer navigator should play.
Cassandra, that's a very good example of a very specific focus for a patient navigator. We have a follow-up comment from Dwight.
And yes, Cassandra, this is Dwight Curry Anderson, and I just wanted to make the comment that I'm going to allow the person in anonymity, but a case manager / social worker here in Atlanta EMA had let me know that for her to relay this information to a client, sometimes we get through, sometimes we wouldn't. But when she had a peer navigator to work with, she said the client hung on that person's every word. And it was so much simpler, and basically what you just stated, it was so much simpler to get things done. It eased her caseload, and it got the client more into compliance, especially regarding their adherence to their medications. And I can say, me personally, allowed someone their anonymity also, making them more responsible for their own situation. There is an individual that is deaf, and I made it incumbent upon that individual to make sure that they get their own interpreter instead of asking people to do it at the last minute. That seems to work very well, and the person is now taking responsibility of making sure that they have their interpreter when it's needed.
So Dwight, thank you so much. Those are perfect examples of how the program should work. It really is. It's about part of empowering people to engage and be responsible for their own care, but really being a support to the clinic staff. As the case manager said, we, sometimes because we've been doing this work for a while, we assume that it's easy. And I don't mean that. I think that people who work in HIV/AIDS services are certainly compassionate people and want to support and provide services to clients. I think that and I think that's clear in the work that we deliver on a regular basis. For someone just learning this information, even the term ADAP, we use acronyms that people are not familiar with. I had to catch myself when I was doing the training to remember not all of these things people know. I have to remember, I work with the feds, the federal government, quite a bit, and so I know a lot of the federal acronyms for programs, but most people do not. And so sometimes folks won't stop the nurse or the doctor and say step by step, I don't understand this, but they'll tell the patient navigator or the peer, and that person can work with the treatment adherence nurse to say, I don't think the client really understood it. Maybe you could walk him through it again. So it's it can be a very supportive relationship. And during these budget constraint times that we have in the state of Georgia, not only in the state of Georgia, across the South, most of our sites are seeing furloughs because of state budget cuts. Having this kind of paraprofessional data to work with the staff can be a great enhancement for ensuring that people who are at high risk don't fall through the cracks. Leah, are there any other questions?
I think you answered them, but I'll read them to you. The two questions that I have left, and just for a time check, it's 11 o'clock,
Okay.
is can you give a brief overview of the qualifications of a patient navigator, and how long would a client typically work with a patient navigator?
Okay, those are very good questions. The qualifications, I won't go over that again. We put some details in the slides, and we sent specific job descriptions to the Atlanta EMA, and they can share those with you. They have electronic job descriptions from some of the other cities and states who've implemented these programs with the salaries. I gave you an overview of what those the general range for the salaries were on the screen. and then the time frame. So it depends. What I would say is 6 months to a year at most. And when I say that, that's not on an ongoing basis. That means somebody who is newly diagnosed, we saw that it can take up to 60 days for them to get through the first screening and intake process. So having the patient navigator work with the case manager to follow up, so that's the first 60 days, or let's say the first 3 months, the person gets fully into the system. The person is in the system and now needs to access, let's say they need to access HIV/AIDS. They want to go to one of the basic HIV/AIDS education courses. The patient navigator can link them to the AIDS Atlanta course, can tell them about it. Say, you can sign up for it. It goes on an ongoing basis. These are the times. Provide them with that information. The person comes back and needs dental care. They work with their case manager. The case manager gives them the referral. The patient navigator may say, now, sometimes it takes 3 months out to get an appointment there. This is the information that you need to take. You can also ask for a backup in case you're not able to get an appointment sooner. And so that's the type of relationship, but 6 months to a year. It's not meant to be an ongoing. It's not, as I said, a buddy or companion program. It's just to provide information, particularly for those who are at a high risk for not remaining in care. And should be, the interactions usually are short, and there are specific questions that a peer navigator can answer or triage. It's very important that the peer navigator know which questions they cannot answer. And so what the peer navigator's role then is to go to the correct person on the clinical team to get the information to the client and make sure that it happens. Are there any other questions?
Sandra?
Okay.
Sandra? I think Candace would like to make a few remarks.
Okay, thank you, and thank you all.
Well, Cassandra, I just want to thank you because for those of you who don't know, she is out on the West Coast, and you probably started this call, 6 o'clock your time?
It was 7, but yes, thank you.
So, but I just want to really thank you and CAI for the great work y'all have done to help us in developing a model for us here in the EMA. And I guess I saw a comment from Tony. Tony Redmond asked the question if this was ready to go to priorities, and I just want to speak briefly on that. I do want to say that we've had quite a few conference calls recently. One as recently as yesterday about navigation, and the recurring theme in that I heard quite often throughout is that navigation programs, an essential element of those programs are persons living with HIV disease. So I think that, and as it has stated, the data shows that. So what we're looking for here, I believe, and I say we, the grantee, is looking for a navigation, a team approach where you have a lot of individuals working together to complement each other. Patrick used the analogy the other day. It's like a relay race where we're passing off the baton from one to the other to make sure patients are leaped and retained. So we're looking at a program that has where you're working with medical case managers, the clinical staff, linkage coordinators, and the navigators as well. So that's what we here in the grantee's office envision, with a focus on treatment, because Brown White Part A, we are a treatment program. So when we talk about navigation, we look at it in terms of care navigation. So I just wanted to say that, and it's a great opportunity for us to place navigators in settings that where you can really be able to engage the client from the initial time of when diagnosis and carry on. there are a couple things that I think need to happen. First of all, we already have peer counseling standards here in the EMA. And as we were talking here as staff, our discussion was, are we just looking at a peer program that is really an expansion of what we currently have? So one of the things I'd like to ask the QM committee is for them to get together and look at our current peer counseling standards to see if we need to make some modifications. I know when we looked at them yesterday, we realized that there wasn't a whole lot of language in there about, what was it, qualifications, or they were very broad, very, very general. So I would like for the QM committee to look at that. Another thing is we're having a providers meeting next week with all of our agencies. And one of the questions I'm going to ask them is those that receive peer counseling, to ask them to tell us how they're currently using their peer counseling staff, and how can peers be most effective in their settings. Because one thing we realize that even though we might have some standardized guidelines or job descriptions or whatever, each clinic may be different and their needs may be different. So next week when we have the providers meeting, we're going to ask that question to our sub-grantee. We will have an opportunity to make some preliminary recommendations to the priorities committee on June the 14th. And I'm hoping that, and also Sandra is giving me the high sign. The 24th? Okay. That's even better. That gives us an additional 10 days. So to get more information. So we'll have an opportunity to make a preliminary report to priorities on June the 24th. And remember, this is when priorities will be making recommendations for fiscal year 2014. So we're talking about a discussion about what we can do in this implementing any model in 2014. So I know people get a little confused, but because our 2013 funds they're already in place, what we're talking about is programs to start in 2014. And unless anyone has any other questions, that's all I have.
Okay. Well, Candace and Patrick, again, from CAI, from Ciccatelli Associates, we thank you for the opportunity to provide information to the Atlanta EMA. We will provide the summary information with the other job descriptions, as I mentioned, from Alabama as soon as we have those in hand. And at any time, feel free to contact us. We're available to you. So thank you all so much for listening today. And we hope the information was helpful to you in your decision-making process.
And again, thanks to you all. Yes. And go to bed.
Okay, thank you. Thanks, Leah.
Thank you so much, everybody, for participating today.
Bye.
All right. Bye-bye.